Okay, some people heard about it. Okay, so again, we talked about how diabetes is associated with hypogonadism or low testosterone. Usually, diabetes is present in the context of a metabolic syndrome, where you have someone that is, maybe overweight, not have a healthy lifestyle, and it's not just insulin that's affected; it's the production of testosterone and normal testosterone production. And so this can have really profound effects on a man. So what is testosterone used for? Well, in the uterus, it helps to make boys look like boys, okay? In the absence of testosterone, the baby's gonna look like a girl, all right? So in uterus, it makes a boy look like a boy, all right? Again, at puberty, it makes the boy get the secondary sex characteristics like, deep voice, hair, penile length, all those kind of things, okay? But it does also a lot more than that, right? Testosterone receptors are on most organs in the body, including liver, muscle. So if you don't have testosterone, then the problem is loss of lean muscle mass. It's been associated with depression. It's been associated with coronary artery disease. So all these bad things associated with it. So, people sometimes think about, well, I have erectile dysfunction. Oh, I need to get my testosterone checked. Well, the fact is, testosterone is important for libido or sex drive. So you can give a guy that has low testosterone and erectile dysfunction testosterone, that will make them have more desire to have sex, but if they have erectile dysfunction, then they can't do anything about it. So generally, you treat both the low T and the erectile dysfunction, okay? So, so what are some signs and symptoms of low testosterone? Low sex drive, erectile dysfunction, fatigue, decreased muscle mass, depressed mood, important comorbidities, and like this would be obesity, diabetes, okay? So, let's talk about, and one of the treatments I'm going to talk about, it's been around for a while, but I think it's been underutilized in this area. Most people have heard of shots of testosterone or the gel, but there is a Medicare covered product that's an implant called Testapel that's been around for a long time. Testosterone has been produced since the 1930s. There's been implantable pellets synthesized and approved as early as 1972. So about 47 years, a testosterone pellet has been available, but it's just not been marketed, and most people don't know about it. In Testapel, which is this implantable pellet, was made available in 2008. So it's been around for at least 11 years in its current form. It's really the commercial option that is, we can do in the office. It's a very brief procedure, make a small incision in the hip, kind of the fatty area of the hip, and put these testosterone pellets in. Generally, we can implant those every 3 to 4 months. So it is important to maintain steady state levels of testosterone for that time. So if you look at the other option, the gel, you can rub gels in daily to replace the testosterone. The issue with that is if you have a granddaughter, you don't want to get that on her, or else she may grow whiskers or have a deep voice, right? You don't want that. Or you forget, like you go out of town, you forget to bring it, and then you're not on the medication, okay? And then there's a cost difference. I mean, generally, depending on what your insurance is, generally the gels tend to be fairly expensive and cost prohibitive. There is shots. The shots, where you come in every 2 weeks and get the testosterone injection, it's more cost effective, and that's what most people out here take are the testosterone shots. And then there are patches too; those tend to be pretty expensive. And then finally, the implant. Has everybody heard of Biotin or seen the ads for Biotin, bioavailable testosterone? The issue with that is it's not an FDA approved product, so the provider gets away with charging cash for something that you can get through an FDA approved product that Medicare covers, okay? So that's an important point. That's why, you don't see Testapel being advertised a lot because it's an FDA-approved product and Medicare does pay for it. Biotin, same thing, right? It's a formulated testosterone pellet, but the provider can pay, can charge cash for it. So anyway, Testapel is what you want to ask for. It's been well studied. This is how we put the implant in. You lie on your side. We mark the area where the incision is, and then place it in through a little trocar, and then put in either 6 or 12 pellets, depending on what your insurance will cover. Medicare generally covers 6 pellets every 3 months, whereas if you have a PPO, that would do 12 pellets. You could do it every 4 months. So, obviously, if you have prostate cancer or a history of breast cancer, you should not take Testapel. You should not have testosterone replacement. But here is a published study of, what you would do, where your testosterone is with the shot. You get an immediate improvement, and then it goes down. Generally, it's about 2 weeks that the shot lasts. The Testapel is within this range the whole time. And then this slide shows the number of pellets. So this pink line is 6 pellets, and the red line is 10 to 12 pellets. So you get within the good range here for at least 3 to 4 months with the Testapel. So any questions so far about erectile dysfunction or low testosterone? No? Clear? Clear as mud? All right, can we load? Let's load. So we'll switch gears and talk about incontinence. Incontinence in women, okay? Okay, does everybody know what urinary incontinence is? Okay, so, urinary incontinence, what's the definition? It's the involuntary loss of urine that is demonstrated, that you can objectively demonstrate, and is a social problem or a hygienic problem. So it's gotta bother you, okay? How common is it? It's very common. Prevalence increases with age. You're looking about at least a quarter to a third of women have urinary incontinence, and about 10 to 15% of older men. If you're in a nursing home, basically that goes up to about 50%. That's a huge problem. It's a very common problem. So, if you look at so what is the anatomy? What's involved with normal urination? Okay, well, the bladder. Okay, so the bladder muscle, and then the external and internal urethral sphincter. A normal bladder holds about 300 to 600 milliliters of urine, okay? So about half a liter, okay? Generally, people get the first urge to urinate at about half that, at about 150 to 300 cc's of urine. Your brain is what controls, ultimately what controls urination. So, you can think that, if you have problems that affect the central nervous system like stroke or dementia or Parkinson's or any one of those, that's very common for people with those conditions to have urinary problems, because this is where the control is of urination ultimately. There's also peripheral nerves that control it, and that's why people that have had spinal cord injuries, how they have bladder problems too. They have bladder problems because the nerves going to the bladder are severed, and then the bladder doesn't have any input to tell it when to empty, okay? And this is just a slide. So it's actually fairly complex, the control of urination. And overall, the concept's easy. You think, well, the bladder stores and it empties. It stores and it empties. but there is a lot of nervous system control from your brain to the spinal cord to the peripheral nerves. And what do we talk about? Nerves and diabetes. This is where diabetes can have the effects, is by damaging the nerves that go to the bladder, and people can get an atonic bladder that doesn't work. But it can be more complicated than that, because people with diabetes are also fall in this category of, they've got a 50% chance of having urinary problems anyway, or 25 to 30%, right? So it kind of complicates things. So you can never really think of diabetes just only itself, because you got to think about, well, what other problems would a person this age typically run into? And now they do have diabetes on top of that, okay? Age-related changes here. She's celebrating her 100th birthday, smoking a cigarette. Over time, what normally happens is that with age, the bladder doesn't contract as well, the bladder doesn't hold urine as well, the person has a decreased ability to postpone urination. The lack of estrogen in women can cause vaginitis, which has a host of issues related to enjoyment of sexual function, but also can play a role in urinary incontinence and prolapse as well. What are some risk factors for urinary incontinence? Well, impaired mobility, right? That's a big one. So if you're just not able to get around as much as you could previously, either you're in a wheelchair or you just can't get there in time, a lot of people just can't make it to the bathroom and do that. Depression, stroke, diabetes is a big one, Parkinson's, dementia. Again, all this because the brain plays a big role in control of normal urinary function, okay? So what are some consequences of incontinence? Well, if you're constantly leaky, the skin can break down and you can get infections. If you're having to go to the bathroom more frequently, you're getting up and down, you can fall, you get a hip fracture. This happens a lot, social withdrawal. People just don't want to go out of the house because they're afraid that they're going to be embarrassed. And that happens actually quite a bit. And the overall cost is pretty staggering. You look at $16 billion for incontinence. And you just look at the cost of diapers alone. It's fairly prohibitive. So, people think of incontinence as one thing, but really it's not. There's let's say, there's 4 different categories of urinary incontinence, okay? There's urge incontinence, where if you have a bladder that's overactive, the classic example is, you get home, doing the dishes, you hear the sound of running water, and then, oop, I gotta go. Okay, that's the bladder contracting, okay? Stress incontinence is if you have leakage, if you lift something heavy, or you cough or sneeze or something like that. It can happen to both men and women. With men, it could be after a prostate surgery, if you have your prostate removed, or if you have damage to the sphincter. One of the most common categories in women is mixed. So it's a combination of stress and urge incontinence, okay? And then overflow. Overflow is if like a spinal cord injury patient, or if you have such bad diabetes that the nerves going to your bladder just don't work. What happens is that the bladder fills and it just kind of dribbles out. So it's this constant kind of dribbling process. That's overflow incontinence. So the reason why we kind of group them is that the cause of these different types of incontinence differs, and so the treatment of these different types of incontinence also differs. So when you come into see me, for instance, in the office, our goal is to determine what kind of incontinence you have, and if you do have more than one type, what bothers you more, and then to identify what treatments we can do for each one of those types of incontinence. Some things that can commonly occur in the hospital, let's say half the people hospitalized can be caused by delirium or urinary tract infection. These can be causes of transient incontinence. You got a UTI, you're more likely to be incontinent. So what's the treatment? Well, you treat the UTI, okay? There are, certain medications, so if you're on, Parkinson's or some anticholinergics, of which Benadryl is one of them, Atarax is another one. Sometimes they can make you retain too much urine, and so that's another thing that we would evaluate when you came in. Other medications, if you're on a diuretic, so it's normal if you're on Lasix, if you take the Lasix, to have to go more frequently afterwards. Why is that? Well, it's called Lasix because it lasts 6 hours, okay? And it causes the fluid to be excreted for 6 hours. So if you take the Lasix and you're having to go frequently for the next 6 hours, that's normal because your body's expelling all that fluid that went out in your tissues, okay? Other things like caffeine. Caffeine could be a bladder irritant, can cause an urgency, okay? So there's a host of medications that you could be taking that causes these issues. And again, pharmacologic causes, why is that? Because again, the bladder, it's a muscle, but it's under nervous system control. So a lot of the medications that you take may affect the nervous system as well, okay? So here are the different categories again. Let's talk about an example. So you look at Miss W, 65-year-old female. She's got increasing urinary leakage for the past several years. She has a past medical history of high blood pressure. She takes a thiazide diuretic, has a heavy history of smoking in the past. The symptoms, generally what we want to know is, how long have you had the problem, what previous treatments that you've been, and then, what position you are when you have the leakage. Is it when you walk only? Is it when you're lying down, which could indicate something more severe? Protection, how many pads a day do you have? And then is there a problem? Does this affect your quality of life? Oftentimes what we'll have you do is, and when you come to see us in the office, is we will have you do a bladder diary. And that will keep track over, a 1 to 3 day period of time, what you drink, how much you urinate, and when you leak, and then roughly, if you're wearing pads, how many pads, are they wet, are they damp? Because that's what we use to gauge response to treatment overall. And a word about treatment is that people are looking for a cure, right? We get a man on the moon, all these great things, but in reality, when it comes to urinary incontinence, we're looking for improvement, and we're looking for improvement that can improve your quality of life. But cure in a lot of these cases isn't generally possible, okay? By virtue of the fact that you're looking at medications that can show some improvement, okay? And so that's why we like to keep a record of these things. So getting back to Mrs. W, she doesn't have any leakage with cough or bearing down, but she does report leakage when she can't get to the bathroom in time. All right, so you have someone that has an urge, she can't get to the bathroom in time. So what kind of incontinence would this be? Urge incontinence, right? So she has urge incontinence, right? Doesn't leak with cough or Valsalva. She just can't get to the bathroom in time, so diagnosis is urge incontinence. It's the most common type of incontinence. It is because the bladder contracts and you don't want it to. It's really unpredictable. Generally what we do is, if you have incontinence, we do a bladder scan to make sure the bladder's empty. And most of the time with urge incontinence, the bladder empties normally. Okay, what are the treatments? There are some really great treatment options for urge incontinence, okay? First, we start out with behavioral modification, which is, things in the diet to avoid alcohol, caffeine, spicy foods, okay? Those can have a lot of impact on, bladder urgency. Other things we can do are do timed voiding, so you can go to the bathroom every 2 hours, okay? And so you'd want to try to keep the bladder empty, avoid bladder stimulants, reduce physical barriers to the toilet. I mean, this is easier for men, right? You can give them like a bedside urinal, or in women you can try to set up a bedside commode. But getting up at night many times it can be a risk factor for a hip fracture or something like that, and it's very important to think about that. Okay, there are a number of different medications called anticholinergics. Ditropan, Detrol, Vesicare, Enablex. All these are anticholinergics that help to relax the bladder. As a class, these medications have a side effect of dry eyes, dry mouth, constipation. They can also cause urinary retention. There's a newer one out called Myrbetriq that is not an anticholinergic. It works on the bladder through beta receptors, so a different mechanism of action to cause basically the same effect. But because it's not an anticholinergic, you get much less dry eyes, dry mouth, and constipation. The only side effect really that we're concerned about that it has is high blood pressure. So we just monitor your blood pressure if you're on Myrbetriq. When you come to see us, what we're looking for are there reversible conditions that we can help overcome without medication or surgery, or are there something that we're going to need to do as urologists to help diagnose this and to treat it. So one of the things we look at is a post-void residual. So when you pee, how much urine should be left in the bladder afterwards? What's the normal, when you go pee, let's say you got 500 cc, half a liter of urine, you go pee, what's the normal amount to have afterwards when you're done? Generally it's less than 50, okay? So that's one of the things we want to measure. Generally, if it's 1 to 200 cc's, we're not that concerned. Clearly, if it's over 300 to 400 cc's afterwards, we get concerned, right? When this is a problem with diabetics. Diabetics that have neuropathy that affect their bladder doesn't drain, they get residual urines over 400 to 500. What happens? That urine backs up into the kidney, and it can cause swelling, and it can cause the kidneys not to work. So this happens, and the saying is, the bladder's a poor witness. So what you think may be going on down below when you go pee may not be accurate. Your body, you want to trust your body to tell you if there's a problem, but when it comes to your urinary tract, that may not be the case, okay? You may be retaining a lot of urine. I can tell you, about once a quarter, I'll see somebody that says, hey doc, I'm peeing fine, and we do a bladder scan and check, and they're retaining 500 to 600 cc's of urine. They didn't know it. You look at them, they almost look 8 months pregnant. We put a catheter in, we drain their bladder, they say, oh, that feels better. But, the real risk with these guys is that they can damage your kidneys. And there's some people that actually, that's how they present. They need dialysis, and it's too late, okay? So, that's why it's important to understand how your anatomy works, and especially if you're diabetic, you may be at higher risk for having a problem, one of those problems. Another type of incontinence is stress incontinence, second most common cause in aging females. What is it? It's the impaired urethral closure, and it's usually due to the fact that there's some degree of prolapse where your bladder has dropped. That's almost always associated with it. And so when there's an increase either with pressure in your abdomen, either due to cough or sneeze, that because the body is no longer in correct anatomic position, there's no longer a support, and you have the leakage as a result of that. And so the bottom line is that the leakage occurs with increasing abdominal pressure, which can occur with exercise, with standing up, with lifting something heavy, okay? And so, what are the various treatment options for stress incontinence? The top treatment for stress incontinence is generally surgical, all right? It's to fix that. It's to fix the backboard of the urethra. And normally it's the vaginal wall that you fix with a sling, mid-urethral sling or something like that. There are other, we do pelvic floor muscle exercises. Another common one that we like people to use are Kegel exercises. What is a Kegel exercise? When you pee, it's the muscle that's used to stop urination. So when you're doing a Kegel exercise, that's the muscle that you're working on, that you're trying to strengthen, is that muscle that stops the urination. The pelvic muscle exercises, obviously requires a motivated patient. It's really good for urgent continence, and focus on the pelvic muscles. Generally you want 10 contractions, 3 to 10 times a day. but you don't want to contract everything, down in your pelvis. You want to focus on just contracting that muscle. For people that have a hard time identifying what that muscle is with Kegels, we can actually refer you to a pelvic floor muscle therapist, a physical therapist that specializes in this area, which, for some people that don't want to have surgery, it's actually a very good option. There are different types of surgical procedures for incontinence. There's slings, there's bladder lifts, there's bladder neck suspension, other things. So if you're not a good operative candidate, you can have a pessary inserted, which is kind of a plastic shaped donut that goes into the vagina that basically reduces the vagina and helps to support the bladder. There's bulking agents. So there's a lot of good treatment options. Here's some examples of pessaries on this side, and it's just inserted in through the end of the vagina, and it helps to support the vaginal wall and the bladder. This is a really important, concept right here, is that this is all affected as you get older or with childbirth. If you've undergone multiple vaginal deliveries, this is really one of the things you can blame your kids, right? They can blame you for a lot, but you can blame them for this, right? Because they did this. But it's basically a restoration of the normal anatomic position. And then finally, the dreaded catheter. A catheter is used for people that are retaining urine. Now, a word about how the catheter works. It's a tube that goes in through the bladder, and it's held in place with this balloon. Okay, so don't ever try to remove a catheter on your own. Let a nurse or someone remove it, because you don't want to be pulling that out through the urethra. Mixed incontinence, again, this is a combination of both urge and stress incontinence, and the evaluation and treatment is just kind of a combination of the two options. Treatment for urge incontinence, treatment for stress incontinence. Just a short word about urodynamics. People that have complex urinary incontinence, we generally like to use the urodynamics. It can help us to determine what part is stress, what part is urge, and generally it's used for people that have had prior pelvic surgery. It's a simple procedure we do in the office. It takes about an hour. It involves putting a catheter in the bladder, one in the rectum, filling the bladder up. These different catheters have pressure transducers, and we're able to calculate exactly what's happening with that bladder, with the bladder muscle. Finally, I want to talk about overflow incontinence, and it's usually due to either the bladder not working at all. Okay, so you have a bladder that doesn't contract and urine just leaks out, or significant obstruction, like with men that have a completely blocked prostate. You tend to get continuous small volume leakage. But people, people will complain of dribbling, a weak urine stream. The management, if you have an obstructing prostate, the management is to treat the prostate. In women, you can get an obstruction like this for severe prolapse, where the urethra actually kind of kinks off and it doesn't drain. So the treatment of that would either be a pessary or a prolapse repair. And finally, a functional incontinence, which is probably more of an issue in a nursing home or with someone with poor mobility. It's just they're unable or unwilling to get to the toilet because of physical impairment. Okay, so it's our job to really figure out, what the different types of urge incontinence are. Okay. All right. So, any questions so far about erectile dysfunction, low testosterone, or incontinence? Okay, there will be a short test at the end. To leave, you have to answer 80% correctly. No, I'm just kidding. All right. So anyway, the last part of the presentation is on BPH. Okay, so again, so how is BPH involved with this? Well, diabetics tend to have problems with bladder function because of nerve damage, but generally, if you're over the age of 50, you're going to have problems with urination because of an enlarged prostate. Okay, so again, the treatment options are similar in the two. So what I want to talk about is what is BPH, how is it diagnosed, and what are the treatment options. You know, in men, the anatomy is clearly different than women. That last slide that I showed you, you know, and so in this sense, men are more complex in that there's a bladder, there's urethra, and then there's a prostate that surrounds the urethra here. And, you know, it's the function of the prostate is to produce fluid to support the sperm when you're trying to make babies, okay? But really, when you get older, it just supports your local urologist. It doesn't do any good for you anymore, okay? The prostate starts at a starts growing at a very young age, and then really grows again at puberty, and then again at the age of 50. And most men over the age of 50 will have some kind of problem. It's, you know, BPH is different than prostate cancer, and it's not prostatitis. Prostatitis is an inflammation or infection of the prostate. So each condition affects the prostate differently. You know, so if let's say, for instance, you know, if you live over the age of 80, you've got about a 90% chance of having BPH. In the U.S., nearly 40 million a year are affected. What is BPH? It is the clinical term for an enlarged prostate. It itself is not cancer. It's not an indicator or predictor of cancer. PSA, which is a tumor marker for prostate cancer, rises with BPH and prostate cancer. So PSA alone cannot tell you what the issue is. You know, this is a really important slide. In a normal bladder and prostate and urethra is right here. This is what happens over time when you have a prostate. Picture the prostate is kind of like a vice that closes off the urethra. So over time, what happens is that the bladder, which is a muscle, contracts more. You know, it has to work more. And what happens when, you know, the bladder works more, or any muscle works more, right? It gets bigger. So you get a thick wall bladder, which is problematic because, you know, if you look at skeletal muscle, if you work it out harder, it actually gets more coordinated and it works better. But this is not skeletal muscle, this is smooth muscle. So when you work out smooth muscle, it gets less coordinated, and that's when you get an overactive bladder, urgency and frequency in the slow urine stream. So the problem is, you know, once you get to this point, you can't really go back. So the idea is to intervene sooner in the process in order to prevent this from happening. So not treating an enlarged prostate can lead to bladder deterioration. Okay. So over time, you have BPH enlargement that occurs that obstructs the urethra, and we actually see these are real patient pictures that we took at the time of the scope. We looked at through the urethra in here, no obstruction, partial obstruction, and complete obstruction. So this is something that we can evaluate in the office. You know, what are the symptoms? Frequency, urgency, getting up at night, hesitancy, weak urine stream, okay? It affects the quality of life. You know, how does it do that? Well, if you have to go to the bathroom 3 or 4 times between here and Dallas, you may have a problem, right? If you can't play a round of golf without going behind the bushes a couple of times, you know, if you can't sit through a movie, you know, all these could be problems, okay? For nearly half of the men in the U.S. with BPH, their symptoms are severe enough to disrupt their lifestyle and cause them to seek treatment. There's 20 million men each year. That's a lot of people. So, you know, how do we diagnose an enlarged prostate? So if you come in, you'll complain of the symptoms. We'll do a bladder scan just to make sure you don't have overflow. You're not retaining a lot of urine. Do a prostate exam to screen for prostate size, texture, and then we'll have you fill out a questionnaire. And included in that questionnaire is how much your urinary symptoms bother you. You know, other studies that we may do is a ural flow, where we'll ask you to pee in the machine. We'll measure your urine flow rate. We can do a urodynamic study. We can also do a size of your prostate with an ultrasound, and then a scope looking through the urethra and the bladder. The questionnaire will have these 7 questions and rate them on a scale of each one at 0 to 5, so the total score could be 35. It's an international validated questionnaire for BPH, and generally we treat people that have moderate to severe symptoms that affects their quality of life. And this is really what we use to monitor the effects of treatment. And we know, what the treatment options are, and we know roughly how effective each treatment option is at improving these symptoms. So there are various treatments for BPH. There's medications, there's surgery like a TURP or a HOLIP, and there's a newer option called the Urolift. What we do to start out with, you come in as we go over your diet history, much like with female incontinence, what things do we recommend to avoid, alcohol, caffeine, spicy foods. If you're getting up 5 or 6 times at night, don't drink, don't sit every time you wake up, drink out of your 36-ounce glass of Coke at the bedside, So generally you want to avoid fluids after dinner, in that situation.
Dr. Walsh?
Yeah.
Please reiterate to my wife that I do not need Mexican food every day.
She's the boss, man.
I know.
All right.
See that nod there.
Okay. So, all right. So most people have heard of Flomax or Proscar or Avodart. Flomax is an alpha blocker, and it generally can improve the symptom score. So let's say that questionnaire. It's like a 35-point. At 0 to 35, how many points do you think the Flomax improves your symptom score? Anybody have an idea?
5.
5 points. Yeah, that's about right. Yeah, generally Flomax can improve that symptom score about 3 to 7 points. So let's say you scored a 30 on the symptom score, and I give you Flomax. You're going to score about a 25 afterwards, right? And severe symptoms are over 20. So medications are mildly effective, but that's the rub, is that they're not that effective and they have side effects. So Flomax as an alpha blocker can cause dizziness, low blood pressure, okay? The other problem, and this is really a big issue, is that if you're a guy, you've been on Flomax, is that it doesn't prevent bladder deterioration from happening. So these guys that have been on Flomax for 30 years are showing up now, retaining urine, needing a catheter, and they're like, well, I've been on Flomax, why did this happen? Well, the reason is because Flomax doesn't prevent bladder dysfunction from happening. The newer modality that I want to talk about is called the prostatic urethral lift, and it's really unique in that it's an in-office procedure. It has absolutely no sexual side effects for treating BPH, and we can do it with a local anesthetic, and generally the procedure itself takes about 10 minutes, and then you can get off the medications. Covered by insurance, and it's a really good option. It has about 11-point improvement in symptom score, so it's twice as effective as medication. And there's well-controlled studies. It's been studied not only nationally but internationally, dozens of well-conducted papers, trials that have been published. That's the benefit. The downside is that it is a urologic procedure, so it's not pleasant to have. But like I said, people in the studies, it's always been done with a local anesthetic. I've treated over 600 patients with this. I actually wrote the article on how to do it in the office. It was published with the 5-year data. So I've got a lot of experience with this, and people are really happy with it. I just got to, as a personal note. So how does it work? Well, we put a scope in through the urethra. The prostate itself is spongy, so we use the scope to compress the prostate. We fire the needle through it that implants the suture. We replace it on the other side, okay? And then we do a series of those to create an anterior channel through the prostate that really opens it up enough to where you have good urinary flow. More traditional therapies are heat or steam-based therapies. These are done in the operating room with the general anesthetic. Put a scope in and either use a laser or some kind of loop or something to remove prostate tissue. So think about the prostate like an orange. These TURP or a laser green light work by taking little bites out of the tissue or vaporizing the tissue. Obviously, size is an issue. So if you have a really huge prostate, these wouldn't be effective treatment options for that. Okay. you know, with these type of procedures, they are done in the hospital with an anesthetic. Afterwards, you'll have a catheter in overnight. They can be associated with erectile dysfunction. After a surgical procedure like this, you won't be able to ejaculate afterwards, so it'll be dry. And then also there's a small risk, about 2% risk of urinary incontinence. Okay, you know, how does a TURP, again, a TURP or a laser therapy, a TURP works the same way. You use a loop and you're basically removing little chips of tissue as you go through. One of the newer modalities which we offer here at Titus is called the holmium laser enucleation of the prostate. And it's a little different concept in that we put a scope in and we use the beak of the scope to remove or separate the adenoma from the capsule. And then we push that into the bladder and use a morcellator to grind it up and remove it. So instead of taking little bites, think about it like an orange. You can either take bites out of the orange, but then you leave all that fruit kind of behind, and you don't really get it all out, or you can peel off the fruit from the rind, and that gets the most amount of tissue. And that is certainly the case for the HOLA. It is, you get more tissue out per unit time, there's less bleeding, and there's better outcomes long term. If you have a catheter, this HOLA is about 95% effective at getting rid of the catheter. You know, no other treatment has that much success. So we went through a lot of information because, you know, to be honest with you, diabetes affects all these systems. So it's important for you to know kind of if you have any of these issues, that there are treatment options available. And you know, our staff, we'd really like to help out and see if we can improve your quality of life. So appreciate you coming out here, and then we'll have some questions.
Which one of those is known as a roto-rooter?
Yeah, I would say, you know, the most common would be a roto-rooter, would be a TURP. That's where you put the scope in, it has a little loop, and you use the loop to cut out tissue.
If you put in the sutures or stitches, how long is that going to work? How long does that procedure seem to
Yeah,
help?
so if you look at the Urolift here, they published 5-year data that shows durability. So where your symptoms are at 1 month is where you're going to be at 5 years. Now, they stopped studying it at 5 years because that's how long they, you know, designed the study for. So it's probably longer than that, but yeah, at least 5 years.
Can you do it again in 5 years?
Yeah, you can do it again in 5 years. Or, you know, or you can go on to have, you can do this and go on to have, you know, one of the more invasive procedures too. Any other questions? All right, well, hey, thanks for coming out and enjoy the rest of the week.
Awesome.
Folks, we do have a couple of door prizes, and we're just so happy to have Dr.